Welcome to Pivot Point, the show where we discuss insights, strategies, and industry trends that encourage growth for your business. I'm your host, David Slepak, and I'm thrilled that you are here with us today. Joining us is Ark Family Health CEO, Kendrick Johnson, who built a direct primary care medical practice for individuals and families to help them take control of their health care. Dr. Johnson works very closely with employer groups, specifically to help their employees receive high-quality care and employers reduce cost of their health insurance plans. Dr. Johnson, thank you so much for joining us on the Pivot Podcast today. I'm really excited to talk to you about how you partner with employers specifically.
Yeah.
So let's jump right in. What's your journey? How did you get into medicine? What's the story behind Ark Family Health?
All right. If I get long-winded, you'll just have to cut me off. But I do feel like I was kind of led to the space that I am from experiences that I had from a pretty young age, actually. My father was a physician, and he's my hero. Just this amazing person who, when I was probably 5 or 6 years old, I was in a supermarket with him, and what I remember is I was holding his hand, and a woman came up to us and said, "Did you know that your dad saved my son's life?" And I'm not sure if that's exactly what happened, but I remember tears in her eyes, thanking my dad, and thinking, wow, that is the way to impact people. That's what I want to be. I want to be somebody like that. And so, planning to be a physician all through school and getting into medical school with this dream of helping people, reducing suffering, making people's lives better. And I came to medical school and was a little bit surprised right off the bat. It didn't feel like we were talking about doing things that really changed people's lives. We were talking about reducing risk of certain chronic disease. We were talking about decreasing the symptoms of certain diseases. But I didn't hear like reversing disease or preventing disease, curing disease, like those words. Like, you don't hear the word cure very many times in medical school. Some people might be surprised to hear that we don't talk about cures very often. And as I progress through medical school, I'm working in hospitals, and I'm seeing all these people with diabetes and strokes and heart disease and cancers, and I'm wondering, when do we learn how to prevent these things? Since I wasn't getting it in school, I was looking other places for, is there science about prevention of disease? And it turns out there is some good science out there. I mean, the American Journal of the American Medical Association, the New England Journal of Medicine, all have published studies about preventing and reversing disease, but all of it comes back to nutrition and exercise and sleep and some of these lifestyle factors that we just really weren't talking about in medical school. And so, coming into residency after medical school, I'm starting to practice medicine, and I'm thinking, well, it doesn't matter if nobody else is going to be reversing or preventing disease. I'm going to do this, And the reality hit me pretty soon that the system was not set up for spending 40 minutes with a patient to try and help them figure out how they can eat better so they can reverse their diabetes. And when somebody comes in with knee pain and you have to figure out how to help them first work on their depression so their knee doesn't hurt as bad and so they can change behaviors, that's just not built into our healthcare system. And this is a long-winded answer, but a moment that I remember in my third year after medical school, somebody came into the clinic I was working in. It was an executive from the company that I worked for, and he said, your clinic is doing really well. You guys almost broke even this last year. And I said, well, how could that be that almost breaking even is doing really well? And he said, oh, yeah, well, all of our primary care clinics lose at least 10% per year. So then the question is, why are you buying up all the primary care clinics? Why are most primary care clinics in the Phoenix area owned by big hospital companies if these companies are losing money on primary care? And the answer, I believe, the one that makes sense to me is that if you lose money on primary care and you make money in the hospital, then probably you buy primary care in order to feed into your hospital. And I know you don't want this to be a controversial podcast, but I guess what I don't believe is controversial is the idea that if you are not making money in that part of your business, then you are not in the business of preventing and reversing disease. If you don't make money by preventing and reversing disease, then you're not in that business. And that's when I decided I just was not going to work in a system where the incentives were backwards. And so that's when I started thinking I was going to build something else.
Yeah, it's funny. Being in this industry for so long and working with physicians and really understanding both the supply side of healthcare, so, providers and pharmacy and DME and all those pieces, right? And then the demand side of, we'll call it the employer services and benefits and whatnot. It's very clear that major hospital systems use and have devalued primary care, right? And almost look at it as marketing dollars, right? So what the CEO of that company was telling you was, our marketing dollar spend was neutral, so you did a great job, right? And in many cases, right, providers of these major hospital systems that buy up primary care doctors, they're contractually obligated to send those patients and make the referral into the high dollar services, whether it be colonoscopies or imaging, where those services in the hospital are 3 to 5 times more than the outpatient, down the street, or the imaging center, the freestanding imaging center down the street. So, I mean, you're spot on, and we're highly aligned as to kind of how, the primary care, and it's funny when, in my opinion, what I've seen, at least on the cost side of healthcare, right, is when you put primary care first, right, and value up and remove all the barriers to primary care, employers and employees spend dramatically less, right, than if it's the reverse way, right? If you start in the ER, that's a fundamental failure. When I analyze groups that start with their primary care doctor in a relationship with preventative, right, and addressing these core issues, now it's a winner, right? Everybody's costs go down, which is really important. And the most important thing is, when the costs go down, that's a direct line of sight to the health of the population of that group improves. And that's really, why I'm in this business. And I know, based on what you said, why you're in this business is to change people's lives, right? To build those things up in a meaningful way to make an impact, right? So it works out really well. So a follow-up, and I know you explained how you got into medicine, which is just a remarkable story. And that's so exciting with your father and kind of you recognizing through medical school one of the early kind of fundamental failures of our healthcare system. And now you're engaged in this medical solution or primary care solution called DPC. So take a minute and share with the audience, today, what's DPC or direct primary care?
Sure. Well, I mean, that kind of just picks up right where I left off. I'm thinking I don't want to be part of a system with the incentives that are backwards. And I'm thinking, should I just quit medicine? Should I, start my own practice and not worry about making enough money? And it was at that time that I came across some medical practices in Kansas that were doing a model where they just charged a monthly membership, and that monthly membership included all the primary care services. So there's no copay to go see them, and there's no limit to how much primary care you get for your membership, and they don't bill insurance companies. So it's just separate from the insurance model, and for a very reasonable fee, under $100, you can get access to your doctor as much as you need them, and they're doing hour-long visits or 40-minute visits, and they're seeing patients same day, next day, and they're available weekends and after hours as needed for urgent things, and all included in this fairly low-cost membership. And so what immediately caught my attention was that now my incentive is to keep people well, as opposed to, get more money by having them have more sickness to deal with. And so that was exciting to me, is this idea of all of your primary care is included in a membership where I'm incentivized to do my best work to keep you as healthy as possible.
Makes total sense. I've been engaged in the healthcare system and working with DPC practices, around the country for quite some time. I personally use, the services of a DPC physician. And it's interesting, when I got into this business model and started learning more about it, the huge advantages that you describe from a patient's perspective. I mean, it's just a totally different type of experience, right? And I'm sure as a physician's perspective, you're not, in this rush, I got to see a patient every 5 minutes, right? And turn and burn, because you have to make it in volume, right? So, I mean, I've spent an hour-long appointment with my primary care physician, and he was ready to go for like another 30 minutes. I'm like, dude, I appreciate the time, but I got stuff I got to do. So it's just a whole different animal, and I think, like you said, the incentives, right, when going to a membership-based model is just, it changes the entire dynamic of the relationship. It takes the economies out of the deal completely, and everyone's really focused more on the care, right? Than necessarily the economics of what exactly is transacting, right? Would that be a fair assessment?
Yeah, I think that when you, even if you have made an oath to put your patient's care first, your patient's well-being first, in every human that I know's brain, there is a tendency to think what is best in this situation also happens to be what is best for my pocketbook, and that's how we get millions of cardiac interventions that we now understand to be unnecessary still happening, just because, well, it seems like the best thing to do for the patient when it also happens to be the best thing for the provider's pocketbook.
Sure. And I mean, look, everybody needs to earn a living and keep the lights on and do what's right for their family and provide those things, right? But when the economics are kind of unaligned, that can go sideways. And I talked to tons of doctors like, man, I wish I could spend more time with my patients, right? I wish I had the time not to spend doing a bunch of charting and weird stuff, filing insurance stuff. Gosh, if I just freed myself from this burden, I'd be able to do these. But I'm kind of roped into a system, and I think that's fundamentally part of the problem, right? This system that continues, and until you just extract yourself from it, right? That's the only way, right? If you don't want to play that game, you just go start another game somewhere else. And I have a mentor that I work with over the years that kind of hit that into my brain, right? Like, you don't like this game, just go start a different game and do it that way. And I think what you're doing is just remarkable. So let's go to another question. So we're talking about challenges in the healthcare system. What would you think, maybe like 1, 2, or 3 different biggest challenges that as a country, right, or as a provider, as an employer, as an employee, as an individual, what are those challenges that you see in the healthcare system today?
Sure. Well, I'm probably not smart enough to really diagnose the complexities of this system, but I can tell you that there are a couple of themes that seem to be very likely at the heart of the biggest challenges of healthcare that I can see. And one of them is the absence of connection between value and shopping. When you think about what has happened over the last 20 years when it comes to consumer electronics, for example, we just see this year after year dramatic improvement in what technology is capable of doing. And then you look over at the healthcare side of things, and there's not a lot that's different from 20 years ago in terms of what you see in an average doctor's office. There've been some interesting and exciting breakthroughs, a lot of expensive breakthroughs, but Americans actually are living shorter lives than they were 20 years ago. We're not like increasing the American lifespan over the last 20 years. So we're getting more and more expensive, but we're seeming to get fewer and fewer returns on that. And the reason I think that might be different in healthcare than in consumer electronics, for example, is that when I go to buy a phone, for example, there are multiple options. And I choose the option based on both price and value. And so I think that has a lot to do with why we don't see better improvement in the value that people are getting. And I have a sneaky suspicion that it also has to do with why the costs continue to go up, because there's really no connection. When I take my insurance card in and it costs me the same to get the $500 drug as it costs to get the $10 drug that gives me the exact same benefit, statistically in every study, this generic drug is just as good as this brand name drug, and yet I don't worry about that. So I get the brand name drug. And I think that fundamental disconnection is why we see increasing prices without increasing quality. And then the other thing that I already mentioned was just incentives. If the companies that are in charge of helping you be healthy make less money when you're healthy, they may not be super well incentivized to do a good job of doing that.
Sure. And I think, when we started today's podcast and discussion, you talked a lot about, cures, right?
Mm-hmm.
And I kind of get drawn to like root cause of things. And it, in my opinion, a lot of the healthcare system today and some of the practices that have not changed, right, is, essentially we're just putting Band-Aids on, the cut, as opposed to figuring out like, why did we get cut, right? Or we're treating diabetes with whatever, as opposed to, gosh, could we do these lifestyle changes to fundamentally make sure that you're off Januvia, right?
Yeah.
Or metformin, or whatever that might be. So talk to me a little bit about kind of this thought process around kind of root cause, or as a DPC doctor, what you're seeing and kind of your mission there.
Sure. Well, the first thing that comes to my mind is a conference I went to last year about diabetes. This was a major conference with the experts, were there, and we spent a full day talking about drugs. It was this drug and then that drug and then this drug. And at the end of the conference, they had a panel where all the experts were lined up. And I stood up to the microphone and I said, hey, is diabetes reversible? And if so, why haven't we been talking about that all day? And I have never seen a longer silence in any conference I've ever been to.
You cleared that room.
It was just like, and it wasn't just the panelists. It was just like everybody else was just looking at me like, what is this heretic talking about? It's like, but there was a long silence and then not much of an answer to the question afterwards. And, I think that goes back to incentives, but the science, says, we have people that go from totally uncontrolled diabetes down to normal blood sugar levels just based on nutrition and exercise and sleep. And I see that in my clinic, all the time. We have patients who come in with uncontrolled diabetes and they make lifestyle changes that leads to them having, from every point of view we can look at, no diabetes. We can't detect their diabetes, and that may be something called reversal of diabetes, and it's just not being talked about, but it's definitely possible, and we see it across all the different diseases. 70% of strokes are known to be preventable. 70% of cancers are known to be preventable. 80 to maybe 90% of heart disease is known to be preventable, and we're just not really putting an effort into that.
Yeah, so it's probably a little bit easier for someone to just pop a pill or take an injectable,
right?
And get, hey doc, can you give me a script for,
Mm-hmm.
as opposed to, hey, I'm going to give you a prescription for the gym,
right?
and a nutritionist. Oh my gosh, right? So I see that often, and it takes a lot more work to change a lifestyle, right? As opposed to just popping a pill.
You would know. You've done a lot of work.
I have, yeah. Over the last several years, I've done a lot of work on getting in shape and losing weight and all sorts of stuff. So, but yeah, no pill is a substitute for that, right? In a meaningful way. Other challenges that you see in kind of how the system is organized, or things that you see in your practice on a daily basis, right? I mean, you see a lot of patients. You work with a ton of employer groups.
Yeah.
What any highlights that you want to kind of share with our listeners today?
Well, this is something I wouldn't have known until I really started working with employer groups. But as I looked at how health insurance was sold, it became clear that it's not always best for an insurance broker's paycheck to lower the cost of healthcare for the employers that they are working with. And so I think that is just another element of this incentive structure where we're creating plans, we're creating the design of a healthcare plan, and in many cases, the plan that would be best for both the employer and the employees of that business are not really being presented because they may not be the best option for the broker, the person who's presenting those plans. And hey, I sold home security systems and diamonds before I was in medical school. And, the prettiest diamonds to me also seem to be the most expensive ones, or the ones I would get the highest commission off of. And so I understand that when you have that incentive structure in place, you're more likely to put forth the most beautiful diamond. And I think that ends up, translating to selling insurance plans that are also, probably better for the broker, and not necessarily any better for the employer.
Sure. No, and we're highly aligned there. I mean, that the system, as a whole, everyone is incentivized, from health insurance to, the medical loss ratios and whatnot, certainly depict that, right? I mean, insurance companies have to spend 85% of every premium dollar on the cost of care. They're able to retain 15% as operating profit, et cetera, et cetera. Well, if you're paying $1,000 a month this month, and you're a publicly traded company, and you have a fiduciary responsibility to your shareholders to increase value, the premium has to go to $1,200 next year, right? Because of that 85%, you have to make more money, right? And you have to spend 85% on healthcare. Consultants that are in that commission-based thing, like, if you're getting paid commission and a percentage, and the premiums go up, that's a increase in your paycheck, right?
Yeah.
So we get it, and certainly asking that question, right? Like, how are you compensated? Are you compensated when my costs go down or when my costs go up?
Right.
And I think that's a really important concept to think about. So I am a huge Warren Buffett fan, and I quote him often, and especially when working with businesses and employers. And he has a quote about healthcare that I thought is just remarkable, right? And kind of captures kind of this next thing. So the ballooning cost of healthcare acts as a hungry tapeworm on the American economy. And I think that is so huge. If you look at the cost of healthcare, and fundamentally what's most important to people, right, to take care of themselves and their families, this increasing cost of 10% increase to 15% increase. After 3, 4, 5 years, you have a 100% increase in your healthcare costs.
Right.
It's just unsustainable. And what's interesting to me is, of the 330 million people in this country, right, about 150 million of those people get their health insurance and healthcare benefits from their employer, right? So, that's a huge opportunity for employers, right? And a huge opportunity to kind of influence kind of how those dollars are spent. So I know you work very closely with employers.
Yeah.
Let's talk a little bit about how a direct relationship, right, with a provider like yourself, and there's lots of providers going to this model, right, of DPC. What's this look like? How do you work with an employer to maximize the quality of care, which is so important, right? And then bend the cost curve.
Yeah. Well, the tapeworm analogy, I think, is fitting when you think about an industry that represents over a quarter of our gross domestic product. It's of every $4 spent, more than $1 is going into healthcare, and then you look at how much of that has been defined as waste. The Institute of Medicine did a report where they said that around a third of the dollars going into healthcare is just straight up waste. It's misdiagnoses, it's excessive bureaucracy, it's fraud. It's just all waste, and that's not even really taking into consideration the fact that, according to the CDC and the World Health Organization and many studies, 80% of the disease we're talking about here is preventable anyway. So we're talking about $4 trillion, give or take, and of that $4 trillion, less than 5% is actually spent on preventing disease. So 80% of the disease is preventable, and less than 5% of this $4 trillion is going towards prevention. And I think when you talk about the opportunity of the employer, where, in this town, almost half of the healthcare dollars are being routed through an employer to healthcare, and the employer's opportunity is to direct where that money is going, and particularly the self-funded groups, the groups that are paying for healthcare essentially out of their own pocket instead of giving their risk to Blue Cross or any other insurance company to manage their risk. These employers have a lot of incentive to get good value for their money that they're putting into healthcare. So what we've done is we've gone into these employers, and they instead of just letting their employees go into the system and be routed towards the hospitals and the the high cost care, they give their employees an option to go into a direct primary care agreement, into a relationship with a provider where that provider is incentivized to keep them well and to keep them out of specialist office, out of hospitals, out of, operating rooms, not to avoid needed surgery, but to decrease the need for surgery, decrease the need for medications. And it turns out that's very possible, for a lot of the things that end up in the emergency room. For example, I've done a lot of ER work. And when I work in the emergency room, less than 1 out of 10 of the people that come to see me in the emergency room really need an emergency room. They need a good primary care provider that they can call. And that's exactly what we've been able to do for these employers, is we are that trusted relationship for their employees to pick up the phone and call instead of just end up in an emergency room where, where the incentives are not such that they're going to walk out with a very cost-effective answer to their question.
That makes a lot of sense. I always talk about kind of 3 things, when it comes to care, right? The right care, in the right place, right? At the right time, right? And I think as a country, and as a system, we often miss the mark, as consumers of healthcare, right? Even as a dad, right? I can't tell you how many times where, I don't want to be a bad dad. It's 9 o'clock at night, and next thing you know, we're going to the hospital, an emergency room visit for, a stomach ache or whatever it might be. And those were before the days where telemedicine was very prevalent, or DPC or those types of things. So, I like the DPC model where a provider, a doctor, is helping guide those 3 principles, right? And for the employee, remove another 3 things, right? So care is important, right? And the timing and the location. But for an employee, removing the barrier of time, money, and transportation is also part of that mix. So with a physician kind of guiding that correct place, right? You don't go to the ER because you have a stomach ache, right? You go to the ER because you broke your ankle, or you got hit by a bus.
By the way, it works in both directions. Sometimes as a parent, you might not take the kid to anywhere because you think it's probably fine, and the costs are too high. The parent example is a bad one. Usually it's like the 45-year-old male who doesn't go in and get assessed because it's probably going to be fine. But in either case, the case where you're ending up getting a bunch of expensive care that you don't need, or you're avoiding getting care that sometimes leads to more expensive care in the future because you didn't get the right care at the right time. In both those cases, having a trusted relationship where the barrier is very low to pick up the phone and call, that can alleviate both of those issues.
Great point. It's a game changer, right, for the employees, and really for the employer from a cost perspective. Being able to do the right thing. I mean, it's interesting. When I talk to CEOs and CFOs and controllers and HR folks, they always say, recruiting and retaining and employees are always their biggest challenge, right? And I agree. I mean, that's of all the things that I hear from employers, employees, people are just the biggest challenge. So if you can keep them healthy, if you can give them the confidence to take care of their family and themselves, and leverage the relationship with a provider that's highly aligned to what they're trying to accomplish, is a huge advantage.
One point on that is, why do people stay in jobs? Usually relationships are one of the biggest things that keeps people in a position, and to add an extra relationship that your employee might not want to break by leaving the company, that's something that we definitely see in direct primary care. So you have this have this great relationship with a provider that makes this benefit package really sticky. It makes you really want to stay because you don't want to lose that.
Good point. Very good point. Well, we're kind of nearing our time together this afternoon. This has been extremely insightful, and I'm sure the folks listening today are just going to be full of new information, right, on the healthcare system. Any other parting thoughts that you have as kind of we wrap up the podcast today?
Yeah, I guess I just would like to make the point that, I'm interested in seeing the system improve. I'm interested in seeing, employers not waste a bunch of money on benefits that don't help. And I'm interested in, seeing the people not get the wrong care at the wrong time. But what I'm really interested in is seeing people get healthier, have more fulfilling lives. And I really truly believe that that having an incentive structure that creates real relationships, empowering relationships, or at least allows for those types of relationships to take place, will be the most important factor for many of us in improving our healthcare experience and the quality of our life. So, it's cool to think about fixing a system and revolution and things like that. But when it comes right down to it, I want to see individuals getting cared for in the right way. And I think we're just lucky that there happens to be an opportunity here where we can make money, have a sustainable model and see that happen at the same time.
Certainly a win-win. It's funny. I joke around, the most trusted person in the room, right? The thing that I'm going to follow the advice or do exactly what that person says is the physician, right? The doctor. And it's always refreshing, right, to get perspectives on the folks that take an oath to take care of people, and live their lives, focused on enriching the lives of others. So really, really cool opportunity here for sure. And we really appreciate you sharing some time with us today. And hopefully we'll have you back for another episode here soon.
Love to.
Stay tuned for the next episode coming up in about a week for Pivot Point. Again, my name is David Slepak, your host. And again, Dr. Johnson, thank you so much for joining us this afternoon.
Thank you, David.